So one of the questions that frequently comes up is, how do these results with stent grafts compared to other treatment modalities in the patient population that we're talking about here, patients with long complex SFA ISR? One of the other treatment modalities that physicians often employ in patients with in-stent restenosis are drug-coated balloons. I mean, they have definitely made a major impact in our day-to-day treatment of patients with PAD. However, when we're talking about in-stent restenosis specifically, the results have been less than stellar. There are many studies which have shown very promising early results with DCB and short to medium length lesions, but when you take longer lesions and you follow them out for a period of time, you can see very promising results at 12 months, but with a very dramatic and somewhat precipitous drop-off in patency rates at 2 years. For example, the Leipzig DCB registry, which is one of the largest that's been reported to date, at 2 years, their primary patency rate had dipped down to less than 50%. And it's also important to remember that with more complex lesions with DCB, the bailout stent rate goes up dramatically with increasing lesion length and greater lesion complexity, for example, occlusive lesions and those that are calcified. And in the IMPACT DCB trial, lesions required adjunctive additional stenting. The DEBATE ISR trial was one of the very few that actually had 3-year follow-up data. What was really remarkable was not only the continued drop-off in primary patency rates, but in fact there was a catch-up phenomenon. So at the end of 3 years, there was no difference between the drug-coated balloon arm and the plain balloon angioplasty arm.
It's hard to compare these data to a lot of other devices that are proposed for treatment of in-stent restenosis, largely because a lot of those other devices haven't been tested in similar challenging real-world populations. There's some good data with DCBs, and I use them in my practice, but by and large, they're shorter lesions, that there is a fair percentage of bailout stenting that's required. And if you look at some of the long-term outcomes, you have to be careful what you're looking at. Is it real objective patency, or some of them even use clinical patency, which is probably not the same thing. So hard to make direct comparisons. We certainly need some more comparative studies to get the answers, but at least I'm confident that the Viabond device in Reline Max was challenged in a pretty complex population.